think I missed out about 2 now that I've tried to record. And that one that you and I sat and did share about the snake bite. It's lucky we're here because you can't hear anything on that recording. Nothing at all. All you can hear, yeah, all you can hear is all. That's all that it sounds like the whole time. But anyway, today's is not very long. It's a short one, but an interesting one. Actually extremely interesting because it's not really a topic we've kind of covered before. So, I mean, that's just to tell us what we're going to do, but I just want to give you guys the history because the history got cut off on the next slide. So 61-year-old man presents with a decreased level of consciousness, all right? So 61 years old. Hi, Ricardo, I know you're there as well. You're also welcome to chip in. I'll tell them what you say.
Thank you.
Hi, can you hear you?
Yes, thanks.
Okay, no problem. So, yeah. So what I was going to say was, so 61-year-old man. Now you haven't done the ECG. 61-year-old man is now in front of you with a decreased level of consciousness. What are you considering as your possibles, as your differentials? Yeah, anything. What would lower GC as? That's basically what I'm saying. Yeah, okay. If it was really low. What I'm saying is, what would be the first organ that you would look at? Brain, yeah. You won't look at the heart for decreased level of consciousness. You look at the brain, decreased level of consciousness. Then you would look at maybe the heart, okay, maybe lungs, maybe peripheries, but you start thinking of extrinsic things. Toxins, you start thinking of alcohol, you start thinking of trauma, you know, things like that. So generally things that affect the brain are what are going to cause a decreased level of consciousness. The things from the heart that would affect would be things like high blood pressure, CVAs, low blood pressure, right? Extreme low blood pressure, and of course, clots, you know? So those are the things that you would consider, you know? So it's either vascular or what you call it, something within the brain, all right? So within the brain can be tumors, meningitis, you know, so you've got to think of it in those terms, all right? Now, let's say you do get this patient and he does come to you and you say, okay, listen, I got to send him for a CT, but the physician on call is insisting that I do an ECG. And this is what you get. Let's have a look and see what do we think is going on. So before you get scared, because you can see the terror in your eyes, let's first analyze it. Let's break it down section by section and see what we find. Okay, so let's start with the first thing, all right? I just want to annotate a little bit, sorry. So let's get drawing up. So let's start with our simple thing, all right? Let's start with the axis, okay? So let's just do the drawing over there. So we know we've got lead 1, all right? And lead AVF sitting over there, all right? So let's have a look at those two first before we do anything else, all right? Okay, so we've got lead 1 pointing upwards, right? So we know we've got, let's just get this thing out. Okay, let's leave it on top. Hopefully it should be okay. All right, so we know we've either got an axis that's normal or to the left, all right? It's definitely not in these, all right? I'll just put a line through like that, okay? And then we look at lead AVF and it's also pointing up, all right? So that means electricity is either going there or there, all right? Coming towards it, not going away from it. So we can already cancel that one out. So we've only got a normal axis left, all right? So we know, okay, we've started off in a good way. We've got a normal axis. Now let's look at our rhythm strip, all right? So first, let's have a look at our P waves. Okay, now you guys have been to enough of my lectures. Do these look like normal P waves? No. What looks different about them? They're taller, very good. In fact, extremely tall, isn't it? So what does it tell you about the atrium? Extremely hard. And for the atrium to contract extremely large, the atrium needs to get? Yes, hypertrophied or larger, all right? So immediately we can see we've got an enlarged atrium, okay? Because it's just from the simple P wave morphology, all right? And it's bilateral because remember the first half of the P wave is looking at the right atrium. second half of the wave is looking at the left atrium, all right? And we can see that both halves are actually enlarged. It's not like one is going and then it slowly comes back down. It's quite symmetrical. So it means both of these are enlarged, all right? So even if we stop there, what causes atrial enlargement? What can cause atrial enlargement? Just as a by the way, it has nothing to do with this case. It's just something to think about. What would cause atrial enlargement? Valvular disease, very good. So in other words, if you have a valvular disease of your mitral and your tricuspid, that could very easily lead to it. Anything else? High systemic pressure. So just simple high blood pressure, very severe, can eventually lead to it. High intraventricular pressures, which can be caused by quite a few things. Let's say you've got a ventricular septal defect. The other alternate is atrioventricular septal defects, all right? So in other words, the ventricle is pushing back into the atrium. So there's quite a few things that can lead to all of this, right? Aortic valve problems that are leading to an enlarged ventricle, pulmonary valve problems. So in other words, you know, you can, if you reason it out, you can kind of get to quite a few reasons why it happens, okay? All right, so we know our atria enlarged. Now let's look at the actual PR distance. So we've got 1, 2, 3.5, so that's within normal. And tell me about our QRS complexes. Are they narrow or wide? Narrow, very good. Does a QRS follow every P? Yes, it does. Are they relatively regular? They are. There's just this one that kind of is out of whack, but we don't find it anywhere else, all right? So it might have just been a tracing, or it could have been an ectopic beat, all right? But otherwise, generally, it's quite regular. Okay. What's the other thing you notice about all of these waves? Yeah, the amplitudes are not the same, all right? So the amplitudes go up and down, all right? So that's just something to keep in mind, okay? So generally when the amplitudes go up and down, what it means is that the heart's moving, all right? So like, for example, lead 2 is looking at it, and for a little while, it's kind of gone away, then it's come back, it's gone away, it's coming. So sometimes that can be a pericardial effusion, all right? So pericardial effusion, because the heart's got place to move, so it beats and moves away, beats and moves towards, beats and moves away, beats and moves towards. It's something we call electrical alternance. It's not so hectic over here, but you can just see changes in amplitude. And then it can be other things, you know, for example, a pleural effusion, patient moving. There's a lot of things that can cause it, you know, but it's just something to think about. Okay, all right. Now we've had a look at that. The rate that we have, let me just work it out here. It's 1, 2, 2.5. So we've got more than 100. So we're looking at about 120 beats per minute. So we've got a sinus tachycardia. Okay, we said it's a sinus rhythm, but it's a sinus tachycardia. Okay, all right. Now let's look at each zone. So let's start with the inferior zone. Leads 2, 3, and AVF, what do you notice? Just any abnormalities that you pick up. I mean, we can see the 12 P waves that we know, all right? Our atrium are enlarged, but what else do you see? Oh, let me put on my pointer over here. Not a depression as such, because that's your ST segment over there, all right? And you can see it's kind of in line. But what's this wave? Yeah, you're right. Right. So what's the story with the T wave? Very good. Okay, so it is inverted, right? And we noticed that throughout all of them. Okay, the ST here, you could argue there's a little ST depression, but it's very slight. Okay, what else do you notice about this distance, for example, from there to there, compared to previous ECGs that we've seen? It's a bit long, isn't it? Now, we don't have the exact measurement here, but if you look at what we call the QT distance, all right, normally a T wave comes somewhere around there, agreed. This T wave is just not only inverted, it's late. So we can kind of think to ourselves, we've been through this before, what causes QT prolongation? And if you can't remember, it's fine, but always, I'll give it to you again, all right? So the first thing is all the hypos. So hypokalemia, hypomagnesemia, hypocalcemia, all the hypos, all right? So it could be an electrolyte abnormality that's causing it. Then you have toxins, many drugs, all right, cause that. And we know we've got a patient with a decreased level of consciousness, all right. Then you have certain drugs like digoxin, calcium channel blockers, beta blockers, all of that. And then you also have congenital, all right. So in other words, the patient is born with it. But the most common one, or let's say the one that we worry about, and that's common, is the hypos. So hypocalcemia, hypokalemia, hypomagnesemia, hypophosphatemia, hypo. So how would you check that? With the blood gas. Blood gas would immediately tell you, okay, there's something going on there. And we've got a patient with decreased level of consciousness. So we're thinking, okay, could it be toxins? I mean, toxins could also cause it, all right? Okay, and then we've got this, now tell me, imagine this T wave was the right way around, right? Forget about it being inverted. Imagine if it was the right way around. Okay, we'll get to that just now, all right? So we know that those are inverted, all right? Let's look at AVR before we come to these. Is there anything that we notice? Again, the P waves, these odd looking T waves and things like that, all right? Let's look at the septum, V1 and V2. Not too bad, huh? Actually looks okay. But tell me, all right, let's get to the interesting parts, V3, V4, because you guys have to get back to psych just now. All right, so looking at, yeah, I know, no ECG is done there whatsoever. I'm sure if they had an ECG, they'd all hold it up like, what is this paper? What does it represent? Now, so what do we notice in V3 and V4? Similar to what we noticed here. This T wave. What's strange about it? I mean, is that, imagine this T wave was just the normal way around. What would be odd about it? It's huge. It's freaking huge. I mean, imagine it the other way around, a T wave that's going up that way and coming this way, right? And I mean, it's quite wide. There's quite a lot going on. So it's just that it's inverted. Okay, but it's an odd T wave in any case, all right? I mean, look at it here. I mean, it's deeper than how, it's bigger than your entire QRS complex, agreed? So that's abnormal. So it's not just an inverted T wave, it's an abnormal inverted T wave. What would you suspect? What would you think? Once you start seeing inverted T waves, because we see the same thing, V5, V6, leads 1 and leads AVR, not to such a great extent. But let's just concentrate on what we do see, which is this big inverted T waves. Ricardo, you're welcome to pop in at any time as well. I don't know if you fell asleep on the other side, but yeah. So I mean, what would you start thinking if you saw inverted T waves? That's what I'm asking. Okay, so inverted T waves. What are we always worried about with ECGs and with the heart? Ischemia, very good. Okay, so inverted T waves are another non-specific sign of ischemia. Okay, so this could be ischemia, all right? But where's the little glitch in this whole thing? Our patient didn't present with chest pain, our patient didn't present with any of that. So our patient presented with a decreased level of consciousness, okay? So as much as you have ischemia, or suspected ischemia, what are you also going to do for this patient because he has a decreased level of consciousness? Imagine you're not going to get a history. Imagine this guy, the cops found him on the side of the road, things like that, you know? And then, oh, okay, no problem. We understand. That's fine. Yeah, so I mean, so now you've got this guy with this decreased level of consciousness. You're not going to get history from anybody. So what are you going to suspect? Yeah, you could suspect an overdose, very good. So it could be an overdose of some drug, all right? So the question is then we have to ask ourselves which drugs, all right? So which drugs, now we've got to start thinking which drugs would give us tachycardia and a decreased level of consciousness, all right, that are generally commonly available, all right? So what drugs do you all know? I'm not talking about you personally. I'm talking about in the medical sense, all right? What we've been through this in some areas. Or just throw out a name and let's see if it fits. Think of a drug. The first one that comes to your mind. Okay, ACE inhibitors are not a drug per se, but they are a medication that can be used, all right? And you're 100% right. They can generally, well, ACE inhibitors actually won't cause a tachycardia. They will cause a hypotension, all right? And they won't necessarily cause a decreased level of consciousness, but they can if your hypertension is very severe. Now, let's assume we've got normal vitals or normal to elevated vitals. What else? Because remember, they don't give us a hypotension, nothing. You know, so we're assuming the vitals are normal. Think of another drug. Yeah. Illicit drugs, anything. Okay, very good. Let's think of cocaine. All right. So cocaine, what does it cause? It does cause a tachycardia, that's for sure. It can even lead to ischemia, but does it cause a decreased level of consciousness? No, it actually causes a person to become hypermanic. You know, they flying around screaming and shouting. So it doesn't really fit this. Anything else we can think of? Yeah, ecstasy kind of causes a mania. You know, actually, ecstasy kind of just causes it actually causes a decrease in heart rate. No, an increase in heart rate, but it's unlikely to cause ischemia. Yeah, that's one. The other one you were saying? Very good. So opiates. All right. So what do opiates do to your system? Opiates depress your system. So in other words, your heart rate would go down. Your heart rate wouldn't go up. It may cause a QT prolongation, you're 100% right, but it can cause a decreased level of consciousness. So the only thing that doesn't fit is the tachycardia. Anything else that we know? Any other drugs, toxins, anything that you can think of? Cannabis generally doesn't cause what you might call it. Yeah, it can cause a decreased level of consciousness, you're right, but may not lead to ischemia. Haven't heard of too many stoners dying of a heart attack. No, but you get it. I'm not making fun. I'm just saying now we're throwing it out and we're trying to figure out, okay, where does it fit in? So yes, it can lead to a tachycardia. I've experienced that. And then and a decreased level of consciousness. But generally not associated with ischemia. Okay. Any other drugs that you can think of? So we've kind of exhausted quite a few sets of drugs, right? So the only one that we have covered, you guys didn't think of, was tricyclic antidepressants, right? So tricyclic, no, wait. Tricyclic antidepressants are noted to give you a decreased level of consciousness as well as a tachycardia, but not ischemic symptoms. So what's the chances that this is a drug? Not very high when you think about it, because it doesn't really fit into any of the toxidromes, the toxic syndromes that we know. It's not fitting into any of those. Or the other alternative is it's a combination of those drugs. All right, so that may be one. Okay. If it's ischemic, and if we say that it's purely ischemic, then we've got to assume that this ischemia is also causing maybe the offshoot of clots. Does he have what you might call it underlying valvular disease? And now with the ischemia, he's got leaflet, what you might call it, there could be leaflet damage, things like that. And now he's throwing off clots. It can be that, okay. And in fact, we can go round and round and round and round and try and figure out what's going to go on. And when I give you guys the answer, it's going to be something completely new that we actually haven't covered before. And then I'm going to simplify how you actually look at these inverted T waves, all right? In fact, there's only two answers to these massive inverted T waves, all right? So shall we move on? Do you guys want to see the answer? Okay, let's go to it. First, let's see how close we got, all right? So we said a sinus tachycardia, rate of 110, okay, I said 120. Prolonged QT interval we got, biatrial enlargement, T wave abnormality suggestive of diffuse cardiac ischemia versus intracranial hemorrhage, all right? Now, we're going to learn why that is, all right? So let's go into some of the technicalities. Biatrial enlargement is diagnosed based on P waves in the inferior leaves with a peak. They were big. You could see they were big, all right? If you're a cardiologist, very good. You must sit and you must work out exactly, but we could see that they were big, all right? Large, broad-based T wave inversions with a prolonged QT interval are sometimes found in patients with acute cardiac ischemia. But in the presence of altered mental stateness, they are highly specific for elevated intracranial pressure, commonly due to hemorrhage. As a result, this T-wave abnormality is often referred to as cerebral T-wave pattern. Now, how common are hemorrhagic CVAs? How many do we see a week? About 4 or 5? And we do ECGs on them. Agreed. So we should be looking out for this. Okay. So the exact reason why this happens or why it induces the T-wave pattern is debated. In other words, they're not 100% sure, right? And I'm not going to give you an answer. I don't know. All right. So regardless, the ECG distinction between cardiac ischemia versus elevated intracranial pressure is critical, as misdiagnosis can result in inappropriate anticoagulation of a patient with intracranial hemorrhage. So if you give anticoagulants to somebody who's bleeding, you're going to make the bleeding worse. All right, so this patient had a computed CT, all right, which demonstrated a hemorrhagic stroke with impending ankle herniation. So that's a lot to take in. Basically, if you see these massive inverted T waves in a patient with a normal level of consciousness, start thinking ischemia. If you see these massive inverted T waves in a patient with altered level of consciousness, first thought, hemorrhagic CVA. If the CT comes back and there's no hemorrhagic CVA, then you start thinking of drugs, hypos, everything that we discussed, all right? So this is a pattern that needs to be known because, like I say, on average, we just work the day shift, me and Shuaib. You guys were here also just for the day shift, agreed? And we would still see 4 to 5 hemorrhagic CVAs per week. So imagine in a 24-hour cycle, how many are we seeing? All right, it's like a pandemic. We see more of those than we see of shootings, almost as many as what we see of stabbings and trauma. So it just tells you how common it is. So by doing the CT, it basically tells us, now the reason why you don't, even though we do ECGs, the reason why we're not seeing it on all is because it's with elevated intracranial pressure. So all hemorrhagic CVAs do not necessarily increase intracranial pressure. That's why you won't see it on everyone. But when there is an increase, this is what you'll see. Now, there are other ones as well, which I'm hoping to cover later, other patterns. But this is just an interesting one that's relatively common. All right. What are the other signs of raised intracranial pressure? You said it? Yeah, vomiting. Very good. Yeah, yeah. All right. And do you guys remember the Cushing's reflex? Okay. There's 3 things, all right, that are related to that. Your blood pressure goes up, your heart rate goes down, all right, which in this case was not the case, all right, and your respiratory rate goes down. Okay, so these are the 3 things that are related, but it just shows you how variable it can be. Okay, here's a patient with confirmed hemorrhagic stroke and a tachycardia, which is not supposed to happen. Agreed. The only time it would happen is what they were talking about, ankle herniation or herniation. Once that starts occurring, that's when the Cushing's reflex kicks in. All right. So, but these are things that you must have in mind, right? So that you must know. So how would you treat this patient if you had the ability, which we don't at Madadeni, but let's say you did, you would do a burr hole. All right. If you could, let all burr hole and let all of that blood out. You still kill the patient, because we don't know how to do a burr hole. All right. Now, ideally, the patient should go in for an immediate craniotomy. All right. Remove that section of the skull, clear out the clot, stop the bleeding. So that means you need a neurosurgeon on hand. Okay, which we don't have. So unfortunately, many of these patients have a very poor outcome. All right. But if you work in big first world countries, these are the types of things where the ambulances have CTs and MRIs. They pick it up, take them straight to a place, a neurosurgeon. The emergency physician stands at the door having a cigarette and just calls the neurosurgeon and says, this is for you. And there's nothing else to do. Okay. So now that we've kind of come to the end. So any questions? That's just a joke to finish up. It is though, yeah. A lot of the times we end up doing that. So, yeah.
In our analysis, it said that it was bilateral atrial.
Bilateral atrial enlargement, that's true, yeah. Not necessarily hypertrophy, but enlargement, because there can be hyperplastic or hypertrophic. There's a difference.
So we saw that, it was a really increased T wave and such.
Yeah.
In the case where it would be a unilateral.
those are slightly different patterns. So what you may see, I don't know if I'll be, all right, just try and follow. All right, so I'm going to try and draw it with this. All right, so if you can imagine, let's see what we can use. All right, let's use this thing's head. All right, so that's kind of like a symmetrical enlargement. All right, so what would happen if it was a right wave enlargement? You would actually see it draw out like that. All right, so elongate and then suddenly dip with the back. All right. Other way you'd see do that, all right? So that's what it shows you. Now this is bilateral because it's quite symmetrical like that, if you get what I mean. Sorry, I don't know how to draw that well on this thing either. Okay, all right. But the bilateral atrial enlargement has nothing much to do with our diagnosis here. It was just a finding. Okay. All right. So if there's no other question, if you guys are happy with that, then we'll stop it there. And then next week we'll do an X-ray. And then tomorrow, like I say, we'll cover a case that I found on one of the M&Ms. So if you guys are interested, more than welcome to. All right. Okay, Ricardo, thanks as well. Right.